psoriasis, he took multiple topical medications. But from the last 2 months, he was started on methotrexate 10 mg per week along with folic acid 5 mg weekly. His psoriasis is not under control and is not shifted to rheumatology unit for the management of psoriatic arthritis. On examination, he has the temperature is 100 degrees Fahrenheit, the pulse, blood pressure, respiratory rate was normal. He has active synovitis with the left knee, right knee, as well as the right ankle, without any evidence of other joint involvement or dactylitis. There was nail fatigue and subungual hyperkeratosis. The PASI score was 14% and without oropharyngeal ulcers at that time and lymphadenopathy, and the other systemic examination was unremarkable. Initial labs, CBC-LFT is normal with a CRP of 40 mg per liter. The dose of methotrexate at that time was increased from 10 to 15 and was put on low-dose corticosteroid therapy. Patient was then being evaluated to start biologics for the treatment of psoriasis and psoriatic arthritis. The Hep B, C, T-spot and chest X-ray was normal. Despite of increasing the methotrexate dose, fever, psoriasis and arthritis worsened. At that time, we sent blood cultures, complete urine culture and the skin swab culture to look for the concomitant sepsis. Empirical broad spectrum antibiotic was started and later on infections turned out to be negative and fever not settled. Patient was then being evaluated for HIV. On probing the history, we gave the history of high sexual activity which the patient initially denied, and now patient thrush was also observed in the oral cavity. Rapid antigen test was positive for HIV, followed by 2 times we done ELISA, which also turned out to be positive. Patient was then referred to the HIV clinic, and the HIV RNA was raised with a CD4 count of 350. At that time, methotrexate stopped and the patient was put on heart therapy. After 3 months of initial therapy, virus load was followed, which decreased and fever settled with the improvement of psoriasis and the psoriatic arthritis. And we called the patient for monthly follow-up, or if early, patient developed again the worsening of psoriatic arthritis, or during the reconstitution phase if the psoriatic arthritis worsened. So my question to the panelists are: how often have you seen patients with psoriatic arthritis and HIV?
Experience, how will it differentiate from an arthritis associated with HIV? Arthritis associated with HIV and psoriatic arthritis in your experience?
Okay, right. So, working abroad for about 14-15 years, I've only seen 2 patients having HIV, not particularly with psoriatic arthritis, but inflammatory arthritis. Obviously, it's a quite difficult situation here. The next step, I think what we're talking here is that how we are going to treat this in the future. So, what I have with my limited experience handling is that we go with the CD4 count rather than the wild load. So, with the CD4 count, if you can bring it up to 200 and keep it there, then you are good to go with some kind of disease-modifying treatment. Now, we will come to what actually you want to prescribe, and then take the precautions accordingly. But it's not a very uncommon situation, but at the same time, it's not a common scenario which happened actually, particularly in Pakistan, because since I have Irish, I regularly check HIV status as well, and sometimes, for surprise, it turns out to be positive. And they require for the high-tech biologicals or DMAT treatment, that's a different thing. We need to put it in a specific perspective. So first thing in this case, you need to stabilize the patient, bring the CD4 count of 400, because there must be some systemic illness associated with HIV contributing to the general symptoms as well. So if we could overcome that and then see what we have left, then we can decide for the plan. So that's my take.
I was a rheumatologist to be there as well.
I think it was an excellent case, and we should be really looking out at our patients who really are coming to our clinics with arthritis, psoriasis, and if they generally are not feeling well, they're losing weight, they have fever, features of infection, so we should be screening them for HIV. first, when